to another MedDent Network Wider Research Society presentation. Today's topic is organ donation, which may or may not be coming up in interviews, so it's always nice to have a bit of an idea of what it is and like some laws around it and the ethics about it. So I hope that through this presentation you are able to learn something new, and with no further ado, let's get started. Okay, so to start off, we're gonna be having a short Menti quiz. You can either scan the QR code or I'll put the link in the chat. Which organ is most commonly transplanted worldwide? Okay, correct. It's the kidney. Which principle should guide organ allocation? Yeah, well done. Fairness. Now going on to the third question. What is the main function of a donated cornea transplant? Yeah, to restore vision. Fourth question. Which statement about living donation is correct? Yeah, that's correct. It requires informed consent. Now, the final question. Why should donation wishes be discussed with family? Okay, we've got a mix. So the correct answer was to support the donation process. I hope you liked this like short Menti quiz, and hopefully we can implement it in other presentations. So what is organ donation? Organ donation is the process of surgically removing an organ or tissue from one person, who is also known as the donor, and transplanting it to another person, also referred to as the recipient. There are two types of organ donations. One being deceased organ donation, in which the organs are recovered after a person has died in a hospital setting, and there are two pathways: brainstem death and circulatory death. Brainstem death is a medical condition in where a person has permanently lost the potential for consciousness and the capacity to breathe, which is usually confirmed by two senior doctors as it's required by law. And then the second type, circulatory death, is instead the irreversible cessation of cardiorespiratory function. So essentially, the heart and breathing stop, but the brain is most likely still alive. Now, the second type of organ donation is living organ donation, in which a healthy person voluntarily donates an organ or part of one to someone in need, often a family member or close friend, although strangers can also donate to as well. Transplantation involves replacing non-functional cells, tissues, or organs with healthy counterparts that are obtained from another individual through voluntarily donation during their lifetime or after their death. There are three different types of transplants. The first one being organ transplantation. Kidneys, livers, hearts, and lungs are the most common transplanted organs, as we've seen when doing the Menti poll. And organ transplantation is often the only effective treatment for end-stage organ failure. The second type of transplantation is tissue transplants. This includes skin grafts, corneal transplants, and bone marrow transplants. Tissue transplantation can improve the quality of life for patients and also even restore the functions. Then the third type is stem cell transplants, which are mainly utilized to treat cancers and blood disorders. So, organ donation can quite literally mean the difference between life and death. But behind every transplant are complex medical and ethical decisions, which we'll explore in the rest of this presentation. The UK organ donation laws follow an opt-out system. So essentially, if you die and are able to become a donor, it is assumed that you're willing to donate your organs and tissue for transplantation, or else you opt out to do so. In England, this was introduced in 2020. However, there's some excluded groups. For example, individuals who lack mental capacity to understand deemed consent for a significant period before their death. Children under 18 and people ordinarily resident in England for less than 12 months immediately before their death. In Spain, all citizens are automatically considered organ donors after death unless they have explicitly opted out in writing. This approach has contributed to Spain having the highest organ donation rates in the world.
Autonomy refers to an individual's right to make informed decisions about their own body. In the United Kingdom, as mentioned before, an opt-out system is now in place for adults in England, Scotland, and Wales. Under this system, individuals are considered willing organ donors unless they have formally chosen to opt out. Despite this, families are still consulted before donation proceeds. Healthcare professionals aim to honor the patient's recorded wishes while also being sensitive to the family's emotional circumstances. Autonomy ensures that organ donation remains a voluntary and respected choice. Justice and fairness are essential because donated organs are extremely limited resources. Allocation is based on medical emergency, biological compatibility, and the likelihood of a successful transplant. These criteria help ensure that organs are used effectively and ethically. Importantly, factors such as wealth, ethnicity, or social status must never influence who receives an organ. The central aim is to maintain a fair, unbiased system that prioritizes patient needs and clinical outcomes. Living donations. Living donations involves an individual donating an organ or a part of their organ while still alive, most commonly a kidney or a portion of their liver. This practice raises additional ethical concerns because the donor is exposed to medical risk. The donation must be entirely voluntary, with no pressure or coercion from family members or others. Healthcare teams must ensure that donors fully understand the risks and are medically suitable to proceed. Protecting the donor's well-being is a fundamental ethical requirement. Legal issues. The Human Tissue Act 2004 regulates the removal, storage, and the use of human organs and tissues. It establishes consent as a legal requirement and prohibits the buying or selling of organs to prevent exploitation. The Organ Donation Act 2019 introduced the opt-out system in England, aiming to increase donation rates while still allowing individuals to record a decision to opt out. Laws also address this issue of illegal organ trade, which involves the unlawful buying and selling of organs. These regulations protect vulnerable individuals and ensure that the donation remains ethical, voluntary, and safe.
First, what do we actually mean by immunology? Immunology is essentially the study of the immune system, how it recognizes things that belong to our body and things that don't, and how it responds to those foreign substances. Normally, this is extremely beneficial because it allows our immune system to recognize pathogens such as bacteria and viruses and destroy them. However, this can become a problem during organ transplantation. The immune system needs to distinguish between self and non-self. One of the important systems involved in this is the human leukocyte antigen, or the HLA system. HLA proteins are found on the surface of cells and act almost like a biological identification system. They tell immune cells that a cell belongs to the body and therefore should not be attacked. However, HLA proteins are determined by genetics, so different people have different HLA proteins. Therefore, when an organ is transplanted from a donor, the cells in that organ will usually display different HLA proteins from those of the recipient. The recipient's immune system can recognize these differences as foreign or non-self, and this activates an immune response against the transplanted organ. The immune response then causes inflammation and damage to the graft, which can ultimately result in organ rejection. The degree of similarity between the donor and recipient's HLA genes is called histocompatibility. Generally, the greater the compatibility, the more likely the recipient is to tolerate the organ. However, unless the donor and recipient are genetically identical, there will still be some degree of immune recognition and therefore some risk of rejection. There are three main clinical forms of rejection: hyperacute, acute, and chronic. Hyperacute rejection occurs within minutes or hours. This happens when the recipient already has antibodies that recognize antigens on the donor organ. These antibodies can attack blood vessels in the graft, causing blood clots and preventing blood from reaching the organ. This can result in immediate graft failure. Acute rejection usually occurs within the first 6 months, with the highest risk during the first 3 months. It occurs when the recipient's immune system recognizes non-self antigens on the donor organ and mounts an immune response. If detected early, acute rejection can sometimes be treated by increasing immunosuppression, and permanent damage can be avoided. Finally, chronic rejection can develop over months or years. Repeated immune damage can cause progressive scarring of the transplanted tissue, eventually leading to loss of organ function. Chronic rejection is particularly difficult because there is currently no cure other than removal of the graft. So how can we reduce this risk? The first approach is donor-recipient matching. Blood groups can be assessed, followed by tissue typing to compare HLA antigens. Cross-matching can also be performed by exposing donor cells to the recipient's serum. If the recipient's antibodies attack the donor cells, this indicates a higher risk of hyperacute rejection. However, even with good matching, rejection can always be prevented. This is where immunosuppressive drugs are used. These drugs reduce the activity of the immune system and therefore reduce the likelihood of the immune system attacking the transplanted organ. However, the main problem is that these drugs are non-specific. They don't just suppress the immune system against the transplanted organ, they also suppress the patient's normal immune defense. This makes patients more susceptible to opportunistic infections and can cause side effects including high blood pressure, impaired kidney function, diabetes, and increased risk of cancer. Patients may need to take immunosuppressive drugs for the rest of their lives. So, the central challenge in transplant medicine is a balance. We need enough immunosuppression to prevent rejection, but not so much that we compromise the patient's ability to fight disease.
So, when we discuss quality of life, we are not just talking about whether someone is physically healthy. It can be divided into physical, psychological, and social aspects. For example, physical quality of life includes things like pain, fatigue, mobility, and being able to carry out everyday activities, while psychological and social quality of life includes emotional well being, relationships, educational work, and independence. For the recipient, transplantation can have a major effect on these areas. Before receiving an organ, patients may have reduced independence and a significant treatment burden, particularly if they require treatments such as dialysis. There can also be a lot of stress and uncertainty while waiting for a suitable organ. After transplantation, quality of life generally improves because the patient can regain some of their independence and return to activities that were difficult or impossible before. However, transplantation does not completely remove health problems. Patients still need lifelong immunosuppressive medication, and there can be complications or side effects, so their quality of life is not necessarily the same as that of someone who has never had organ failure. It is also important to consider the donor, because living donation involves a healthy person undergoing a major surgery for the benefit of somebody else. A large review looking at over 14,000 kidney donors found that quality of life was worse around 3 months after donation, which is understandable given the recovery from surgery. However, by 6 months and beyond, quality of life generally moved back towards the donor's baseline. So, the effect of donors appears to be particularly important during the recovery period. rather than being a permanent decline for most donors, which can serve as an encouragement to donate. The impact also depends quite significantly on which organ is being donated. Kidney and liver donation are useful examples because the body responds very differently to each. With kidney donation, a person can normally live a healthy life with one kidney, so removing one kidney does not usually cause major limitations. However, there are still long term risks, such as slightly increased risk of high blood pressure and protein appearing in the urine. Importantly, serous kidney disease in the remaining kidney is very uncommon, occurring in less than 0.5% of donors. If that remaining kidney were eventually to fail, the person could require dialysis or a transplant themselves. Liver donation is different because only part of the liver needs to be removed. The remaining liver has the ability to regenerate and restore much of its volume, as shown in the photograph. This means that unlike a kidney donor, the donor is not permanently left with only half of a paired organ. However, liver donation is still a major operation, so there are risks including bleeding, infection, and bile leakage. In rare cases, much more serious complications such as liver failure or even death can also occur. So, overall, there is not one fixed level of risk associated with liver organ donation. It depends on the organ being donated, how much tissue needs to be removed, and how complex the surgery is. It also depends on the individual donor, including factors such as age, general health, and medical history, as well as compatibility with the recipient. This is why potential donors undergo a detailed medical assessment before they're approved. The aim is to make sure that the potential benefit to the recipient does not come at an unacceptable risk to the donor.
Thank you all very much for listening to today's presentation. Make sure to fill in the feedback form if you'd like a certificate of participation. Thank you all so much once again.